hopefully I'll be able to get the link back up on the website. And for social workers who want CEUs, can you email me that you would like CEUs for this and any of the other sessions that you attended? And hopefully you did the evaluation for those sessions, and we're going to give people CEUs if they filled out the evaluation form. So this is the third training in a 3-part series that Dr. Fernandez has graciously allowed to do for us on dementia capability. And today is going to be on strategies for families. So I'm gonna have her start because she has a lot of information to share with you. Thank you.
Thank you, Debbie, and to Executive Office on Aging for hosting the Dementia Capability Training. Executive Office on Aging has a grant from Administration on Community Living that is making all of these trainings possible. A big shout out and thank you to Dr. Christine Ishida, who is our evaluator and will be looking at all these pre-tests, post-tests, and does our grant reporting. And I want to thank each and every one of you for signing up for this Zoom session, because there are two kinds of people. You can either curse the darkness, you can say, oh my God, look at this COVID-19, or you can light a candle. And you are all people who want to light a candle and make a difference. And thank you for being part of the solution, part of the solution makers and problem solvers to the dementia issue on our island. I want to recap from last week. We discussed the 88 and the mini cog, and anyone wants to share about their experience, because I had assigned homework. There was homework to be done from last week to this week. I had requested if you could administer the 88 or the mini cog to your neighbor, friend, church member, family member, and anyone would like to share their experience, we can unmute you, or you can unmute yourself.
I have something to share from Maui. I did the mini cog today because I had a client. Can you hear me okay? This is Donna.
You probably have to speak up a little louder, Donna.
Okay. I had a referral on someone that needed help with medication management. So I used the mini cog today.
Thank you.
To see if they would be pass it, so perhaps they would be capable to fill their own medicine. And I had to go into a dialysis unit, of course, all dressed up with the COVID precautions, and they too were in a semi-isolation state. So there were a lot of things, environmental issues, I think, that may have impacted the score. However, I gave the 3 words. I used daughter, heaven, and mountain because he has a daughter. And I thought, you know, this would maybe catch daughter, heaven, mountain, had him repeat them. And then I told him I would be asking him those again, had him do the clock. And he was, I don't know if I can show you how this looked.
Please share your screen. Let's see if we can all.
Okay, let's see if I can do that. Share screen. And then do I just hold this in front? I don't know how to do this. I'm so sorry. But anyways, maybe I should just, oh, here we go. Maybe I should just explain. Can you see it? Can you see the clock?
No, sorry.
Okay, so we skipped this then. Okay, so I can explain. He started making all his numbers in the upper right quadrant. And I wasn't sure why he would do that. So I will have to say that I cheated because I could see that, you know, there was so much going on. And I said, can you look at the clock up there? And it took him a minute to realize that he didn't have to put all his numbers crowded. And then he was able to do the 12, the 6, the 9, and then the 3. But he did the 10 minutes after 11 correct, but I think there was just too much going on. So maybe I should just do this test again in a better setting.
Yeah, that's a
better
great
setting.
idea. That's a great idea to repeat the test again in another month or so, because there could have been other factors that impacted the test today. And another choice you have during COVID-19, maintaining physical distance and social distancing, is the 88. So the 88 might be easier to administer during these days.
Thank you for
Rita Bell,
that.
did you stop sharing your screen and then?
No, I haven't stopped. Do you want me to stop sharing my screen? I can do
If you
that.
stop sharing, then Donna can share hers.
Oh,
Okay. Okay, Donna.
So
Go to
do I
share
just
screen.
share screen and I just hold this up so you can see it?
Oh, it's on in front of your camera?
Yes. Can you see that?
No.
No, I think you got to be on the computer.
Okay, that's all right. Maybe yeah,
Okay,
I don't
so
want to take up too much time. Thank you.
Yeah, you stop sharing your screen and then Rita Bell can share again.
Did I?
Thank you.
Okay, I'm back. Donna, thank you for doing the homework. Thank you for administering the mini cog. I appreciate your taking the effort to do it. It's an easy test, and there are things that can affect the test. So, you know, administering this in a 1 month from now or 2 months from now is a good idea.
Thank you.
And to all our attendees, I want you, if you're like me and you don't know where things are on your computer and you can't find it, remember you can always find the 88 and the mini cog on Google. These are free of charge, they're freely available, and you can download that form through Google. Now the MMSC, which some of us learned in social work school or nursing school or medical school and learned it in our home countries, the MMSC is no longer free. There is a charge to use the MMSC, but the 88 and the mini cog are free of charge, and you can always find them back on any search engine. So let's look at strategies to take care of people with dementia and to what are the resources in the community. So today we are going to cover how we can help families. And we need to look at the care partners, the team. We need to understand what disease education should we provide. What about safety? Because that's a big component in Alzheimer's, dementia and dementia care. What about behavior and symptom management? Health, wellness, and caregiver support. And I'm going to cover all of these in our 1 hour session today. Let's begin with the care team. Who is the team? Let's look at the patient at the center of the circle. And we have all these care partners that are helping the patient. Now, it doesn't have to just be family. We need to think outside the box. It could be the healthcare team. It could be the church friend, the neighbor. Say if somebody's living alone in elderly housing, it may be the resident manager. It may be a community volunteer, Project Dana volunteer. So there are all different people and members of our community that come together to support a person. And that is the care team. And often things are task specific, like somebody's helping with grocery, somebody may be helping with transportation, maybe another person just takes them to their doctor's appointments. So identify the care team and document it in your note. It's important to write this down. I often write this in my social history in the electronic medical record because I want to know who is the service coordinator, what's that person's name, what's the phone number, or if somebody has a public guardian, write down the person's name, telephone number, so other people in your organization can find that same information. Say if you were on vacation or you had called in sick, other people can help the patient if you have written and identified all the care partners. Next thing we got to think about is disease education. You want to ask the patient, ask the family, what do they know about the disease? What is their biggest concern, their fears, their challenges? Do they think the person is going to die right away? Are they worried about how they're going to live in their home? Because many people, when you ask them, they want to live in their home and die in their home. Most people do not want to go into a nursing home. So ask them what is their fears, their challenge, and try to provide disease education. You don't want to overwhelm them with too much information, but little bite-sized information, little disease-specific topics, small topics, like you could just talk on bathing, or you could just talk about difficult behaviors. Just give them focus and customize the education. So how is dementia treated? We discussed about diagnosis. Remember, we mentioned that there is no single magic test. There's no one test that will diagnose dementia. It's a whole battery of things, including cognitive testing. Now, regarding the treatment, we have certain drugs that improve the neurotransmitters in the brain. So it improves how one neuron, one brain cell is talking to another brain cell. So you have all these acetylcholinesterase inhibitors like Aricept, Exelon, Remino. Then there's another family of drugs called the NMDA receptor antagonist, and that's Namenda. And most recently, you see a combination drug like Namzaric, which has an acetylcholine and an NMDA receptor antagonist. But the not so good news is these drugs are not very effective. So it's not like you give somebody the pill and they become Einstein. They're not going to start remembering stuff and recognizing people and going about what they used to do. What these drugs have shown in the FDA studies is to delay nursing home progression or placement. So it just slows it down a little bit. It doesn't reverse the disease. Maybe their score on the mini-cog may stay the same a little bit, or the slums, their score might stay the same. But you don't see a dramatic change. Now, where is all the new research heading? The new research is heading on those amyloid and plaques and tangles in the brain. If you remember our first session, we talked about what's going on in the brain, and there are the beta amyloid plaques and tangles. So the newer drugs are targeting that particular protein, and it's trying to stop the formation of the beta amyloid. These current drugs only act on the chemicals, the neurotransmitters. So since we don't have such good drugs, what can we tell patients? What education can we give them? This is a beautiful handout from the Alzheimer's Association, and we have included this in your packet of handouts. It's called 10 Ways to Love Your Brain. And these are simple things, but there's loads of research to support exercise. There's loads of research to support good sleep. If you sleep good, the beta amyloid clears naturally during sleep. It's a way of clearing them from the brain. People need good sleep, people need exercise, healthy diet, read a book, learn a new hobby, learn a new language, all different things to keep your brain active. So please share this handout with your clients, with your family, with your friends. Next thing we got to think about when we are working with families is, what about safety? And we need to plan for the 6 F's: falls, freedom, freeways, firearm, finances, and fire. So anytime you have making a care plan, please include safety. It's very important. So what do you do? What is the biggest fear people have when they grow old? They fear falling. And if somebody has fallen down once, they fear falling again. So a falls risk assessment, you could do that. There are many tools online. You got to see, what about the lighting in the house? What about, do they have a walker? Are they using their walker? Do they have a cane? Are they using it correctly? We can also get home safety inspections done, and this is paid for by the insurance company. So a home health, we can order physical therapy that can do a home safety evaluation. If you're concerned somebody doesn't have insurance or money, Project Donna offers free home safety evaluation. They got a physical therapist who will go out. Because remember, these people will look at the home with a very trained eye and will make recommendations like grab bar, lighting, things to make the home safer. What about other things like wandering? if you have somebody who is at a risk for wandering, we need to think about a beautiful program from the Alzheimer's Association called the Safe Return Program. In the Safe Return Program, a person who goes missing can be, the first responders can search for them right away, immediately. So you don't have to wait for that 24-hour rule, because adults are not declared missing until 24 hours have passed. But with the Safe Return, they have their photograph in a database and can look for them right away. How much does this cost? It's between $50 to $60 a year. It's an annual renewal fee, and it's in partnership between the Alzheimer's Association and the MediAlert. What about other safety concerns like driving? Is the client driving? Have they met any accidents, any fender benders? So there's a beautiful booklet from the Hartford Foundation. It's called At the Crossroads. You can call them, order it. You can also download the PDF version. The Alzheimer's Association has some very nice videos that you could show families. However, often what needs to be done is people have to hide the keys, or say the car is not working, or the engine is broken, or things like that, to just disable the car. Sometimes we just have to be creative, because the person might keep going to the car to try to start it and drive. What about firearms? We often don't think of this, and it's important to ask, because if you don't ask, you don't know. So I'll tell you about one time when I did a home visit in the Kalihi Valley. I usually go out with a team, and the psychologist had some students. They were tripler psychology students. So whenever one person is talking to the patient, another we're talking to the caregiver, or looking at the medicines, everybody's doing something in the house. So the student asked the patient, "Hello, Mr. X. So what are your hobbies?" Such a simple, innocent question. What are your hobbies? And he said, "I like to collect guns." And then that opened a total can of worms. Then we realized there was over 40 guns in that house. It took us the whole afternoon. We had to get the cops. We had to get the guns taken away. There was a lot of things, but it just came out through a student asking a simple question: what are your hobbies? So those of you who have students, if you have social work students, nursing students, please remember, students are blessings in disguise. I love having students, because they think of things you might not even think of, and they add another perspective to the case. What about other things like finances? Are you concerned that somebody's taking advantage of the patient? Do we need a power of attorney? Do we need a bill paying plan? You can also get a rep payee. Often as a medical provider, I do the rep payee form for Social Security, because many people, as soon as they get their Social Security check, it's gone in a week. They're buying cigarettes for somebody, they're buying alcohol. It's very hard to plan and budget and strategize your money to last the whole month. So a rep payee is a pretty good solution for those who are simply dependent on their Social Security incomes. What about fire? You want to ask people, you want to ask families, are they cooking? Did you burn the pots and pans? I always ask this: did you burn the pots and pans? Did you leave the faucet on? Have you gotten lost on the bus? So these are all safety questions you need to ask. Encourage people to have a personal home and personal safety plan. We want an emergency plan, especially living on an island. You don't know when is the next tsunami coming. We need to have all of these things, and keep an emergency kit, a copy of the polls, maybe a medication list, simple things like if you have another spare glasses, put the spare glasses in that emergency kit. Put a slipper, just little things. Because often when you call 911 and you're taken to the hospital, you have forgotten all these little stuff. So keeping an emergency kit is very helpful. What about behavior and symptom management? 50 to 90% of persons with dementia will develop behavior symptoms. And if you wonder what triggers a nursing home placement, most people with dementia are living with their families, especially in Hawaii. We're all about ohana, families, and taking care of our loved ones and our seniors. But it's the behavior. When we have difficult, challenging behaviors, that's when the family gives up and says, hey, I can't handle this anymore. I can handle other things, but I can't handle these behaviors. So we need to spend a good deal of time helping the caregiver change their attitude, change their strategies to manage the behavior. The prevalence of behavior is influenced by the care partner's approach. This is such a powerful statement. Many people don't realize that if they simply change their approach, the behavior might go away. All behavior is communication. So whether they're banging on a table or hitting someone, they're trying to communicate something. So one has to think like a detective. Who, when, what, why, what's going on, what's making it worse, what's making it better. So please think like a behavioral analyst to figure out what really is triggering the behavior. Some simple communication strategies. Speak slowly. When speaking to a person with dementia, also when we speak to the person, we need to approach them from the front. Don't talk from the next room. Don't talk from the hallway. Come in front of the person and speak to them. Because a lot of the peripheral vision is gone in dementia. So they lose a lot of their peripheral vision and it's very narrow. So you have to be right in front of them. Use short, familiar words. Ask one question at a time. Give one direction at a time. Redirect the person. Often just simple redirection, distracting them, changing the conversation helps. Avoid arguing or disagreeing. I've added a few slides that I just did last minute. So I want to tell you about breaking down the task. You don't have this one, but follow along with me. If you tell somebody with dementia, take a shower, take a bath, you know how complicated that task is? If you simply wrote down all the steps it takes you to have a shower, you realize there's a lot of steps. So the secret is to break down the task into small, tiny steps. And you do have these sequence cards that are available on the internet if you wish to get them. But the take-home message is try to just simplify, give one short, simple direction at a time, and break down a complicated task into small, little chunks. Another question people have is, should I reorient the person or not? Now, today's best practice in dementia care is do not correct or reorient the person. And this is difficult because it requires for the staff to have a shift in their care philosophy. So let's look at this example. What time is my mother coming? And you know Ken's mother died 20 years ago. Which response is better? A, your mother is dead, Ken. Your sister will pick you up at 4 o'clock. Or B, she'll be here in a little while. Let's get a dish of ice cream while we wait. So how many say A is the right answer? It's technically right, but today the best practice in dementia care is B. B is the preferred answer today. And we need to remind our staff working and new people joining the field and people who've just graduated from nursing school and social work school that we are not lying to the patient, we are joining them in their reality. We are entering their world. We're not expecting them to come to our world, but we join them where they are. Another thing that helps is reminiscence therapy. And by that we mean, let's look at photo albums together. Let's look at scrapbooks. Let's ask them their story. And I'll give you an example. I'm doing a home visit. This is a Samoan family in Kuyo Park Terrace. And the daughter tells the mother, so who is she? So the mother, looking at me, says, "For my." For my in Samoan means doctor. Then the daughter goes on to say, "What is For my's name?" So mother says, "Fernando." Then the daughter goes on to ask, "Where does For my work?" Now mother couldn't say the full thing. She said Kokua. She couldn't say Kokua Valley. And I told the daughter, you know, "Anna, no need to do this. It's okay. Let's stop." She told me, "Doctor, I am exercising mommy's mind. I'm keeping her mind strong." So the daughter thought she is doing the right thing by quizzing her mother. We need to educate caregivers not to do this anymore. For persons with dementia, quizzing doesn't help. It is much better to reminisce together and look at photo albums, scrapbook, old letters, cards, and that is a much preferred therapy. We need to remember that nonverbal communication has a huge role. 93% of communication is nonverbal. Words only matter 7%. And this is proven by research. So we have to educate caregivers to be careful of their tone, their voice, their posturing. All of this matters. Let's look at validation therapy. This is another theory that is used in persons with dementia. An example of validation. John is upset. He says, "Someone stole my book." Now, one response could be, "You're so careless, John. You're always losing your book." Oh, you could say, "You're the one who misplaced it. Don't blame other people." Now, in validation theory, the way you respond to John is, "I'd be upset too if that happened to me. I'll help you look for it." So in validation, we are joining the person wherever they are, and we're meeting them in their world and validating their feelings. I'm moving on to another aspect, which is the health, wellness, and engagement. So all of this is so important. Exercise, good nutrition, stress reduction, meaning and purpose. Another thing that plays a role is a new word is contented enjoyment, meaningful engagement. So you don't put everybody in front of the TV, or everyone doesn't have to play bingo. Somebody wants to play bingo, somebody may play cards, someone may want to paint. Everyone has a different purposeful activity or hobby that they may enjoy. We need to foster relationships, health management, and routine. Nutrition plays a big role, and I've given you a handout on this called the Mind Diet. Please look at that handout. It's got the stuff in green on the top, which you need to encourage, and the red at the bottom are things to minimize. So what does Mind Diet stand for? It's the Mediterranean Dash Intervention for Neurodegenerative Delay. So this is the Mediterranean diet and the hypertension diet, which is essentially low salt. So think of the Mediterranean diet, fruits, vegetables, a lot of olive oil, nuts, seeds. All of this is really good for the brain. So please encourage the Mind Diet. You have a handout and you can give this to caregivers, because caregivers, they want to know what can they do. People want to do something. So you can give them that handout and say, try to encourage these foods. Berries are good, fish. All of this is really popular and good for the brain. Another way of looking at it is what's good for the heart is good for the brain. We want to facilitate regular physician appointments, and now maybe we've gone to telehealth. There's a lot of telehealth going on, but make that appointment. Keep that health, wellness checkups. Some people need refills on their medications. Help them with a medication review. This is so complicated, especially people have so many doctors. They got one primary doctor, then they got a heart specialist, kidney specialist, rheumatologist, and every doctor is adding their own medicine. So it is complicated, and we need to help somebody with a medication list or help them with a pill box. A pill box might help you straighten out the medication. The family member could do the pill box once a week and then follow along if they, you know, remind them over the phone, mom, did you take your medicine, take the morning ones, or you get all of this. Longs has pill box, they got alarms, there's so many ways to help people with their medications. An appointment log is helpful to get people to their doctor's appointment. Maybe as case managers, you do it one step further and you even arrange the transportation. So it's really good to help people on the day itself, give them another reminder call. Your appointment is today. I've arranged the ride for you. You need to get to the doctor's appointment. And if there's something that you want them to make a note of, please let the office know. Please let the nurse know that, okay, there's a new problem. Maybe there's incontinence, or maybe there's difficulty sleeping at night. Don't depend on the person to tell the doctor, because they're going to forget. Usually what happens when people with dementia see their provider, all is well, everything okay, all is good. So please communicate that to the nurse or the office manager. Another thing is routine. We need to encourage routine. And you'll see this at a lot of the assisted living facilities, even foster home, care homes. I've gone and seen on a big whiteboard, they have the full routine program schedule. And we want to get people engaged, because, you know, just putting them in front of the TV and letting the TV babysit them, that's not a useful engagement or meaningful enjoyment. So please encourage routine that is meaningful and tailored to the person. We need to support the care partners, the caregivers. Remember that 70% of individuals with Alzheimer's disease are living at home. They're not institutionalized. They are in the community. This is old data from the Alzheimer's Association. They said this was in 2012, that an estimated 15 million unpaid caregivers provided an estimated 17.5 billion hours of unpaid care. Remember, our system would be broke. We would not be able to sustain the cost of care without the caregivers. So taking care of the caregivers is really important. So when you do your care plan, always have a section. My note, I always have one heading called caregiver stress or burnout. I comment on it if the caregiver is coping well, or if I'm worried about stress, burnout and stress. So what are the risks with caregiving? There's the physical risk of health problems. There's the social risk, because people may have given up their lives. They may have left the mainland, left their high-paying job, come home to be with mom, dad, return back to the island. There may be a feeling of social isolation, which is worse this time now. There's the psychological risk of depression. There's the financial risk, because people may have given up their education, may have given up their job. There's loss of wages. There's the cost of care. So there is a lot of burden from all of these aspects. And with COVID-19, it has raised even more questions. People who were going for daycare or day health, now they're not attending that. They're at home. What about people who have their loved ones in a nursing home? They can't visit them. There's restrictions on visiting. What about persons with dementia? How hard it is for them to understand physical distancing or put on a mask. Maybe they hate a mask. They're going to take it out at every minute. Then there's the issue of testing. There's also so many ethical dilemmas. The ethics committee at Queens had to meet in March to come up with protocol for ventilator use. Who's getting a ventilator and who's not? They had to develop ethical protocols for this, because there is a limited number of these devices. And then there's the grief and loss, not only from the deaths, and we've had a few deaths on our island, but it's also the grief and loss of our old life, because our old life as we knew it is gone. And people grieve that. So COVID-19 has raised more questions, and it just I thank you all for being the ones to light a candle instead of cursing the darkness. And thank you for attending this dementia capability training. I have attached one handout for you called, it's from Beyond Words. And that's a UK, you'll find it on the internet. It's a UK company that has, pictures. They use pictures to describe coronavirus. They use pictures to describe, okay, I'm going to see my healthcare doctor, or I'm going to the hospital. And they're beautiful. They're books without words. And I invite you to explore their website and look at the different resources that they have. What about challenging population like those living alone? There are a lot of people living alone, and some of them have no one to check on them. 30% or more have no support at all. Maybe the Meals on Wheels person who's delivering the meals once a week, that volunteer may be their only contact. Maybe the mailman is their only contact. So this is another population that, we need to think about. Every person with dementia living alone does not need a guardian. So in dementia, when we say, oh, he lacks capacity or she lacks capacity, one needs to understand that capacity for what? Is it capacity to do medication? Oh, I can't do medicines, but he can still drive. Or can't do the finances, can't do the checkbook, but could still do little housework in the house. So can still dress on their own, take a shower on their own. So when we say lacking capacity, we need to understand the capacity for what. And another term to remember that when we talk about incompetent, competence is a legal term. Okay, so we have to remember that in medical language, we are talking about dementia capacity. People can live alone safely, especially in the early and middle stages. And face-to-face visits are important because unless you do a home visit, you wouldn't really realize what is going on. Over the telephone, you might miss a lot of things, but when you do a home visit, you see things that a doctor would never see in their office setting, or you would never know on the phone. So this is priceless, face-to-face home visits. What about assistive technology? It's very useful for people living alone. There are many, many things out there, from GPS wristbands, motion sensor devices. Kids on the mainland can track their parents on their smartphone. There's so many things that can be done with assistive technology today to make the person safer in their home. What about legal and financial planning? We need to encourage patient and care partner to assign a durable power of attorney. So you might consider referring them to an elder law attorney, or what about, do they have a POLS? Do they have advanced care directives? All of these little things have to be put in place. What's the difference between a POLS and an advanced directive? A POLS is a provider order. It can be done by a nurse practitioner or a physician. It is an order that goes into effect immediately. Whereas an advanced directive is a document for the future. You're saying, if A happened, I want this, this, and this. So if I'm in a coma, I would like this. So it's a document for the future. It doesn't go into effect immediately until that circumstance happens. But it's important to have the conversation, because in reality, often these documents never get done. You may give them the form, you may talk about it, it never gets done. But documenting in your note, so whatever the patient said, I keep a whole paragraph on this. I'll just document in the note, because my hopes of getting that advanced directive back has dwindled a lot. My expectation, I've become more realistic now, that very often they're never going to complete it or get it back. So please document in your note what they're saying, what they want, because that will hold. If tomorrow in a court of law, your note will hold. In a hospital setting, your documentation on this conversation will be priceless. Connect families to resources. The Alzheimer's Association is located on all the islands. They are everywhere, and they are on the mainland, and they have a 24/7 helpline. So if you have a caregiver who's having a crisis in the middle of the night, they don't know what to do, there is a 1-800 number that can help the caregiver walk them through a crisis, a behavior meltdown. Visit the Alzheimer's Association. They've got classes for caregivers, because again, the caregiver's attitude, the caregiver's way of handling the patient has a very big role to play on how that person, what symptoms they manifest. So taking these caregiver classes is very useful. They're free of charge. All their brochures are free of charge. Some families want to know, are there any new drugs? How do I participate in a new drug trial? If families want a new drug, the Alzheimer's Association has a beautiful program called Trial Match. So they can match them with trials on the mainland, and they can be a part of the new drugs in the pipeline. Now we have our Elderly Affairs Division, our Hawaii Aging and Disability Resource Center, and that's also on all the islands. So you can tap into our senior network and get help. Please note these two numbers down. These are extremely valuable resources to help patients and families. So this is a whole list of what the Alzheimer's Association provides: care consultation, education, support groups, safety programs, trial match. They also have online trainings and dementia certification. Another very valuable resource and greatly underutilized are our public health nurses. A public health nurse, to get their help, we are not billing the medical insurance. It doesn't matter what insurance you have. Public health nurse is there to help anyone and everyone on the island. And through our other grants, the HADI, the Hawaii Alzheimer's Disease Initiative, we have trained a lot of the public health nurses as memory care navigators. So say if you want the mini cog administered, the public health nurse can do a home visit and administer the mini cog. They can take the client to the doctor's appointment. If you're concerned about somebody living alone, or you're thinking, oh my God, what's going on with this person? Should I call APS? I would say call the public health nurse first. Maybe they can do a home visit and look what's needed and decide what can we do to help this client. We have included in your handout the PHN Referral Form. So all of you have the public health nurse referral form. Please note that when you complete the form, you fax it to where the client is located. So if the client lives on Kauai, you fax it to the PHN office on Kauai. On Oahu, they've got a couple of offices, like say if somebody's in Kaneohe, you'll fax it to the Windward office. So make a note of that, of where you got to fax the referral form. So this is what it looks like. We have included it in your handout. Thank you, Debbie and Christy, who have spent hours with the public health nurses trying to strengthen our network of dementia capability. Another underutilized resource is home health. We have a lot of home health companies on the island, including all the islands, from Care Resources, Bayada, there's a whole bunch of companies. Remember, to qualify for home health, to be eligible, somebody needs to be homebound. Now, the homebound definition by Medicare is very generous. All that Medicare says is that it is hard to leave the home. Leaving the home is a taxing effort. That's it. That's all that Medicare says. Person can still leave the home to go to church on Sunday. Person can still leave the home to go to dialysis and still be considered homebound. Person can still leave the home for a doctor's appointment and still be considered homebound. Patient can still leave for an infrequent haircut and still be considered homebound. So remember, we need to think about home health. If you had somebody who fell in the house, a fall is a perfect reason to say, hey, let's get some home health involved. Maybe this client could benefit from some physical therapy, from some occupational therapy. So it's covered by all medical insurances, and there needs to be a need, a reason. So often for skilled nursing, they might be involved with wound care. Physical therapy could take care of falls, home safety evaluation. Occupational therapy can help with people who need help with dressing, eating, training, retraining. Speech therapy is valuable. If somebody had a stroke, somebody with Parkinson's disease, you might consider speech therapy. Social work, you can also get social work through home health as well as a home health aid. But remember that home health is very short-lived, maximum 1 to 2 months. You don't see home health going on forever, but it's a short-term help to patients and families. Very often, please think of home health when you're discharging from a hospital. It's good following hospitalizations, whether it's CHF, COPD. Home health can help with medication management, bathing, any little thing that a person needs for a short duration of time. What about hospice? Another underutilized resource, because many people think about hospice just for cancer. Oh, he has cancer, she got cancer, and went to hospice. You can get hospice for dementia as well. Advanced dementia qualifies for hospice. Then your question might be, Dr. Fernandez, what is advanced dementia? What does that look like? Advanced dementia is typically when a person is not walking much, not talking much, not eating much, they're losing weight, they might have some bed sores, they may have had a UTI, a pneumonia, they may have gone to the ER. So all these are signs of decline. So often we see patients in care homes, foster home, nursing home, they're just lying in the bed. They don't do much, they're in the bed all the time. Very often those are advanced dementia. Their advanced dementia could qualify for hospice. So hospice is available on all the islands, and please consider referral. Even if they may not qualify, the hospice may check on them in a quarterly or annually, because a person might qualify later on if they don't qualify right away. And important to note is hospice is covered by all insurances and there is no copay. That's the beauty, zero copay. And all DME gets covered by hospice. So you'll get all your oxygen, hospital bed, everything like the same day. Another valuable resource is Kupuna Care. Kupuna Care is through our elderly aging network on all the islands. So the Executive Office on Aging is at our state level, and then the monies go to all the counties to provide these services through Kupuna Care, like case management, adult daycare, chore and homemaker care, attendant care, home delivered meals, transportation, personal care. So Executive Office on Aging or the Elderly Affairs Division, they are not a service provider. What they do is they contract with the community service providers like Catholic Charities or Project Dana. They contract with them to provide Kupuna Care. So what is the eligibility criteria? 60 years of age and older, living at home, so not in a care home or a foster home, but living at home. It could be the daughter's home. It doesn't have to be their home, but they're in the community. And problems with 2 or more ADLs. ADL stands for Activities of Daily Living. So that's the eligibility criteria. And Kupuna Care is very useful for people in the gap, that they're not low income enough to qualify for Medicaid, and they're not rich enough. So there's some people that fall in the gap, and Kupuna Care is very useful. And even if you're on a wait list, it's okay. Put the client on the wait list. Doesn't matter. So please remember, this is a very valuable resource available on all the islands. What about Medicaid? Hawaii's Medicaid is the most generous of all Medicaids. If you compare to the other states, what we cover is far greater. In Hawaii, our program is called Quest, and we have Quest integrated for the aged, blind, and disabled. And they are administered through managed care organizations like United Healthcare, Ohana, Aloha Care, HMSA, and Kaiser. So what can the client get? There's a whole host of home and community-based services, such as personal assistance level 1, like chores, homemaker. There is personal assistance level 2, like bathing. There's private duty nursing, respite, transportation, home delivered meals. PERS is the personal emergency response system. That also is covered by Medicaid. So how do you get this stuff? Like, how do you get a client all of these wonderful things? It starts with the service coordinator doing 1147. 1147 is the level of care assessment, and according to the points that a person scores and according to their needs and their risk category, the service coordinator will approve some of these services or all of these services, or decide that, hey, maybe we need to get the person in a foster home. So please work with the service coordinators. It is so essential. We are all part of the care team. We are all part of the team, so work with them to get these services for your clients. What about veterans? The VA is a valuable resource, greatly underutilized. And why is it underutilized? It's underutilized like the gun story. Unless you ask about the guns, you're not going to know they have guns. So VA, unless you ask the person, are you a veteran? You're not going to know the answer to this. So please ask. When you're looking at all these insurance, you got your Medicare card, you got a HMSA card, you got this card, that card. Ask them, are you a veteran? And what does it qualify to get the VA health benefits? It's active military services for 24 months. That is only 2 years. That means they didn't have to do 20 years. That's for retirement and for getting their pension. Only 2 years of service with the honorable discharge, they qualify and they're eligible. And through the VA, you get another whole host of services like home health, hospice that covers room and board. That's really wonderful that they will pay for room and board. Foster home, respite, home-based care, private duty nursing, caregiver support, housing, transportation. So this is another avenue you can tap into. But it's important to know that if the person is a veteran or not. Often you might find the person is a veteran and they'll say, I hate the VA. I don't want to go to them. I don't want anything from the VA. And it's important to tell them, hey, there is the VA health benefit. There are all these things that we can get through the VA. So it requires us working with clients, working with families to encourage them, to make them see there is the positive side of the VA. There are all these benefits and all of these services that they can get if they have the VA health plan. So they got to apply, and that's important. So a summary of the process, we have this care coordination tool that was created under the Hattie grant. We adapted it from Minnesota's Act on Alzheimer's, and we made it Hawaiian. We put all the Hawaii resources, the 808 numbers, the local stuff like Kokua Mau and all our resources. Please take a look at this. It goes over everything we have discussed, from advanced care planning to safety to caregiver health, all of that. And this is an excellent help in making a care plan, because you want to make a comprehensive care plan for your persons with dementia. So in summary of the process, a client can come through any door. By doors, we mean the No Wrong Door network, whether you are Department of Health, DDD, VA, mental health, doesn't matter where the client can come through. We are trying to train all the doors to be dementia capable. We can administer the ADA, the mini cog, and then help in making appropriate referrals. And I thank you all for being part of the solution, for being part of the Dementia Capability Network on the island and helping Kupuna. I will open up for question and answers. please feel free to write your question in the chat box.
Rita Bell, we did have one comment when you were asking about people doing their homework. So Maureen did respond in the chat box, and I'll read her response. She did the mini cog with her 82-year-old mother, and she couldn't speak because her mother was in the other room. So she said that the mom scored a 1. She got very confused with the clock assignment and couldn't do it and started crying. And it was very sad. I don't know if you have any comment
I'm sorry
for
to hear.
Maureen.
I didn't get how Maureen administered, like they were in different rooms. I didn't get that.
No. Right now, she couldn't respond to you when you had asked about sharing the homework assignment because her mom was in the other room. So she just shared in the chat that she did do the mini cog with her mom, but her mom got so upset that she started crying.
Okay, thank you for sharing that, Maureen. There are 3 kinds of responses you may get when administering these cognitive testing. One response is if persons are crying or they are, I don't know, and they're not trying to answer the question, even a very, very simple question, person might be depressed. So you don't know whether you're dealing with, these are the 3 Ds. They're dementia, depression, delirium. You don't know which D you're dealing with. So a mini cog or a 88 is not diagnostic for Alzheimer's. So if somebody starts crying, maybe we need to, see probably a depression screen or administer it again or look at it again. The other response you get when administering the mini cog is that people start rambling. You're asking them one thing and they're talking about 10 other things. And it is taking like 20 minutes to do the mini cog and you're getting irritated. Why is it taking me 20 minutes? That's a delirium patient. That's a confused delirium patient. So remember, typically people with Alzheimer's, when they are administered the mini cog, they try to answer. Persons with dementia are trying their best to answer. So this may be just a door opening to look at what else could be going on and should we be screening mom for depression.
Okay, thank you. Anybody else? Yeah, anybody else have? Maureen says thank you. Yes, she is depressed.
Thank you for sharing, Maureen.